يا محمد.
ناصر.
اوكي. سلايدات واضحة قدام الكل.
ممكن تكبرهم ناصر؟
اوكي. هيك واضحة.
ناصر
سامعني؟
صحيح.
حرك السلايد قاعد.
آه
اوكي، تفضل دكتور محمد.
يعطيكم العافية جميعا، السلام عليكم. بعتذر كمان مرة عشان التأخير. So this evening we'll have a quick review of the biology of bone healing, which is the essence of orthopedics and a very important topic to understand. Before we go through this, we'll have uh, a look on the basic of bone forming unit, which is the osteon. Now, the osteon is a formal unit in the bone, which is composed of circular lamellar layers of bone, in which there is entrapped some osteophytes and central longitudinal and transverse canals. The longitudinal one that goes with the long axis to bone is called the Hypergean canal, and the transverse ones are called the Boltzmann's ones. And as you see here, the prominent
محمد. محمد، في صدى بصوتك، تقدر
ايش ناصر؟
في صدى كثير بصوتك.
صوت عفوا ايش؟
الصوت كله صدى.
أم،
حاول تقعد محل فيهوش صدى يعني.
بغرفة والله لحالي.
طيب كمل سيدي. اوكي طيب.
Yes, حاول أقرب على المايك. Now, as you see in the slide, the osteon is composed of lamellar layers of bone in which the osteocytes are entrapped and connected with small long processes. Next one يا ناصر.
دكتور محمد سيدي، والله الصوت فيه صدى كثير وفايت ببعض يعني بعد اذنك سيدي مش سامعين شيء.
آه ناصر
محمد، حاول غير مكانك عشان اروح الصدى بس.
أوكي ثواني بس. في في فرق هيك؟ ناصر؟
محمد معك، تفضل.
في فرق هيك أحسن؟
هيك احسن.
Okay. This histological slice shows the basic unit, which is the osteon. And as you see, the central canal is the Haversian canal, surrounded by the laminated layers of bone, and you can see the scattered osteocytes as well. Next, Nasa. Now, this slide is the same osteons, but it shows the transverse canal, the Boltzmann canal that we have gone through before. Next. Now, in general, the bone composition is that the bone is composed of cells and the extracellular matrix. And as you know, we have three types of cells: the osteocytes, the osteoblasts, and the osteoclasts. Whereas the extracellular matrix is composed of organic material and inorganic ones. The organic one is mainly the collagen, and as you know, it is mainly 90% is type 1, and the proteins that are in the extracellular matrix, like the osteocalcin, osteonectin, and proteoglycans. The inorganic component of the matrix is primarily the hydroxyapatite. Next. Now, regarding the osteoclast, is derived from mesenchymal stem cells, and it is the bone-forming cells, and it lines the surface of the bone, and it produces osteoid, as we said. And the immediate precursor of the osteoblast is called fibroblast, like pre-osteoblast. Next. Now, regarding the osteocytes, as we said, it is dormant. We can call it a dormant osteoblast, that is entrapped in the spaces between the laminated bone inside the osteon. The exact function of the osteocyte is not well known yet, but the thought is that these cells play a role in the bone metabolism and the bone remodeling upon exposure to bone stresses. Next. Now, the osteoclast is, we can say that this is the bone-eating cells. They are derived from hematopoietic stem cells, and they are multinucleated. As you can see on the slide, in the middle of the slide, you can see the cell with multinuclei. They live or they reside in the house-shaped lacunae, which is a space in the bone. And notably, we know that the parathyroid hormone doesn't have direct receptors on the osteoclast, whereas it has a direct receptor on the osteoblasts, and the osteoblasts in turn, it activates the osteoclasts. Next. Now we come to our topic. As a general rule, the healing potential of bone is influenced by a variety of factors. These are biochemical, biomechanical, cellular, hormonal, and pathological ones. Next. Now, for a bone to grow or a fracture to heal in our topic, it has to have two prerequisites. The first one is adequate blood supply, or let's say in brackets, adequate biological environment, and the second one is adequate mechanical stability. Next. Now, provided that the fracture site has a good systemic and local biological conditions, the main determinant of the outcome of a fracture is the mechanical stability. Let's say in other terms is the mechanical strain, and we'll come to that in a second. Now, just to remind you that the strain is a physical term, not only in orthopedics, but it describes the change or the percentage, the change that happens in a structure relative to its original size or site upon stress. As you see, we have a long bone here, or which has a fracture in the middle with a gap of 2 millimeters. And after, let's say, physiological loading, the fracture has some movement and the gap has decreased into 1.5 millimeters. Now, the resultant 0.5 millimeter of movement over the original shape, which over the original gap, which is 2 millimeters, equals 25%. So in this model, we describe the strain as 25%. So the shape or the size of the fracture or the gap has changed by 25%. And this is very important piece of information in understanding the types of healing that we'll have in our body. Next, please. So after we went through the idea of strain, generally, as you know, we have two types of bone healing, and this is dependent on the strain that we have across the fracture site. If the strain is less than 2%, we will have what we call absolute stability, and a primary bone healing will occur. And the second one, if the strain is between 2% and 10%, we will have what we call the secondary bone healing. And we can call it as well the relative stability mode of healing. And if the strain is above 10%, the fracture site will go into non-union with its types. Next, please. Now, for the first type of bone healing, as we said, when the strain is 2%, is less than 2%, we have the primary bone healing. Now, in general, we have the term primary bone healing, all of us know it, but we have to stress on this point today that even the primary bone healing, we have two types, the contact healing and the gap healing. Let's say if you have a transverse fracture of the radius and you fixed it with a plate, If you have a strain that less than 2% and there was a direct contact healing, the bone healing that we'll have in this case is a primary one, but we call it the cutting cones primary the bone healing, which means that you have rigid fixation, strain less than 2%, and the two bone ends are in contact. In this case, the body will recognize the fracture site as a normal part of the bone. So there will be no, let's say, a new bone formation, no callus. And the normal remodeling process that comes from one side to the other side continues as normal. Nasser, can you go next, please? So we have this structure, this slide, which is called the cutting cones. Now, normally in our body or in our daily activities, we have, let's say, wear and tear, we have microfractures in our body, and there will be a continuous process of remodeling according to the pressure that we apply on our bodies or our bones. So, cutting cones is a normal remodeling process in our body. In case we have primary bone healing with direct bone contact, this process will continue as normal. So it is, as we said, as you see in this slide, is primarily a mechanism to remodel bone. The osteoclast at the beginning, which is on your right side, at the tip of the cutting bone, there will be osteoclast that resorb the bone, and at the tail of the cone will be active osteoclasts that lay down new bone. Next, Martha. Okay. Now, as we said, the primary bone healing, we have two types. The contact one, we'll have cutting cones with no new bone formation that needs remodeling. Whereas if you have, let's say, a rigid fixation, less than 2%, but we have a small gap, what will happen here? You will have the traditional one that we have, it is the intramembranous bone formation, which is the bone will lay down a new bone in the fracture gap, and this bone will remodel later on. But again, because it's a primary bone healing, there will be no cartilage anal. Next. This is another name, which is the Haversian remodeling. It's the same name for the primary bone healing. And as we said, the primary bone healing mainly occurs with the absolute stability constructs, like the compression plates or the fracture that are fixed with lag screws with neutralization plates. Next. Now, let's say that you have a fracture that is fixed or treated, not necessarily fixed, treated by a method that allows a strain to happen between 2% and 10%. In this case, you will have what we call the secondary bone healing or enchondral bone healing. And we call it enchondral bone healing because there will be, at the fracture site, there will be a cartilaginous precursor that will calcify and ossify later on and turns into bone. That's why we call it enchondral one. And this usually occurs with non-rigid fixation like the braces, external fixators, bridging plates, and intramedullary nails. Next, Nasser. As we said, we call it enchondral bone healing. And this is very similar to the growing child at the where we have the growth plate that has cartilage that undergoes calcification and ossification with growth. This is the same process applies here. The fracture happens, then the callus formation, cartilage deposition, and then calcification. Next, Nasser. This is a gross scheme of or figure about the secondary bone healing. Whereas in number one on your left side, the fracture site happens and the repair process starts immediately with the formation of hematoma. And then we will have the fibrocartilaginous callus formation, the primary one, the soft one, and then the bony callus when the cartilage becomes ossified, and then the body modeling. Next. Generally, the secondary bone healing is divided into three stages: the inflammation one, the repair one, and the remodeling one. Next, please. Now, the inflammation phase starts immediately at the time of the injury. where the patient or the fracture site will have hematoma that works as a source for hematopoietic cells. These hematopoietic cells are capable of transforming into osteoblasts or chondrocytes, and it secretes growth factors and angiogenesis factors as well. Now, immediately the fibroblasts and the mesenchymal cells migrate to the fracture site, and granulation tissue forms around the fracture sites with time. Next. Now, after 2 weeks, roughly, the primary callus will be formed, which is the transformation between the granulation tissue and the cartilaginous tissue. As we said, we call it the inchondral process. And this later on, the cartilaginous model or precursor will be invaded by vascular structures with high oxygen tension, and then it undergoes ossification. So a soft callus, which is composed of cartilage, will be converted into hard callus, which is composed of irregular bone. Now, early, as we said, in 2 weeks, the fracture becomes, as we call it, sticky fracture, or the cartilaginous or the primary callus provides provisional stabilization. Generally, because it is a cartilage, there will be type 2 collagen initially, and with remodeling and ossification, there will be more type 1 collagen. Next. The third and the last phase of secondary bone healing is the remodeling one. And it begins in the middle of the repair phase, and it continues further later after the clinical union. The newly formed bone, we call the woven bone, is remodeled and reorganized by the osteoclastic activity balanced against the osteoclastic activity. Next. Now we said that we have primary healing, secondary healing. Now, what if the stabilization of or the treatment is not enough to maintain this process of transforming the soft callus into a hard callus? What will result is excessive deformation at the fracture site, and the fracture will goes into a non-union. Next. Now, important information to focus on that, especially in surgically treated fractures, both types of healing might occur in the same fracture. Next, Nasser. Now you have this distal humerus fracture, which is C2. You can see that there is an intra-articular component, which is a simple one, and there is some metaphyseal comminution. Let's say if you do a lag screw across the fracture site at the articular surface, here we will have primary healing, strain less than 2%, and primary bone healing. Whereas in the same fracture, after fixing the articular surface, if you put a bridging plate across the metaphyseal comminution, you will have a relative or secondary bone healing. And by this, you can have two types of healing in the same fracture. Next. Now, we will go now to the factors that affects the fracture healing. The most important one is the blood supply. Now, initially, after the fracture occurs, there will be immediate interruption or decrease in the vascular supply to the fracture site. However, within few hours or few days, there will be the blood flow will increase and will be vasodilation. This peaks at 2 weeks and normalizes at 3 to 5 months. And a clinical application of this, that the unreamed nails is better than, from this point of view, is better than the reamed nails, because they maintain the endosteal blood supply, and hence has better healing from this point of view. Next. Some other factors like the hormones, and we know that the estrogen has a bone protecting effect, and it stimulates the fracture healing. However, the thyroid hormones and the corticosteroids, they have osteoclastic activity, and hence they reduce the rate of fracture healing. Next. The parathyroid hormone especially the intermittent exposure. It stimulates the osteoblast and increase bone formation. The growth hormone as well increases the callus formation and fracture strength. Next. After going through the process of fracture healing, there will be some factors that some are systematic one and some are anatomical local ones that might affect the fracture healing. As you see from the image on your right side, whatever you fix this fracture, the soft tissue will play an important role in the healing of this fracture. So the status of soft tissue injury, interruption of local blood supply, as we said earlier, interposition of soft tissues at fracture site, and the previously irradiated or chemically treated patients, all these factors will play a role in the healing of a fracture. Next. We'll go through now some systemic factors that affect the healing. As we said, the most important local one is the blood supply. Now, regarding the systemic factors, we have the diet. They noticed that the majority of patients who went through non-union had some metabolic issues, and two-thirds, 66% of them have vitamin D deficiency. Next. Diabetes mellitus, it affects the fracture healing in multiple aspects. It decreases cellularity at the fracture calyx, and it causes delayed endochondral ossification and diminished strength of the fracture calyx. And usually the patients take 1.6 to 2 times longer time to have healing more than patients who doesn't have diabetes. And this is a very important clinical point. Next. The smoking is very important as well. It decreases the rate of fracture healing and inhibits the growth of new blood vessels as the bone is remodeled. And especially in spine fusion patients, the smokers have 5 times risk of pseudoarthrosis more than the non-smokers. And the smokers will have 70% time longer to have a healed open tibia fractures than non-smokers. Next. And the last thing that we'll go through is some medications. The bisphosphonate is a type of treatment for the osteoporosis and is known to have the side effect, which is the atypical subtrochanteric fractures. But regarding our topic here, recent studies demonstrated longer healing times for surgically treated wrist fractures in patients on bisphosphonates. So bisphosphonates negatively affects the fracture healing. Next. Now, the systemic steroids, it affects the fracture healing as well, and some studies have shown that there will be a 6.5% higher rate of intertrochanteric fractures, non-unions, in patients who use a systemic steroids. Next. And the famous daily medication that we use to treat the pain in patients who have fractures is the non-steroidals, and they prolong the healing time because they inhibit the COX enzyme that is important enzyme in the process of healing, especially in the inflammation phase. And notably, the quinolones are toxic to chondrocytes and diminish fracture repair. Next. Just a small point to focus on is the application of low-intensity pulse ultrasound on the fracture healing. It has a clinical use, but exact mechanism of fracture healing enhancement is not well known, but most probably it increases the vascularity. It accelerates the fracture healing and increases the mechanical strength of the calyx. Next, and thank you. الله يعطيكم العافية. Any questions or comments?
يعطيك العافية دكتور محمد.
الو،
الو.
اذا في سؤال تفضل. الو.
تفضل دكتور رازي، تفضل سيدي.
اذا ما في حدا عنده سؤال انا بدي اسال سؤال، يعني لازم يكون في سؤال ولا مش معقول يا جماعه؟ بدي
تفضل.
اسال اذا في اي حدا من المقيمين عنده فكره which stage of healing، احنا بنوصف الستيجز of healing، which stage of healing exists in bone before a bone fractures, before a bone breaks. في حدا عنده سؤال؟ اذا مش واضح السؤال برد بعيده.
دكتور رازي يعطيك العافية.
الله يعافيك.
دكتور فيصل خريشة معك.
هلا فيصل،
كيف
تعطينا. هلا.
كيف اتوقع الريموديلنج فيز، لانه احنا يعني دائما البون الريموديلنج فيز دائما
بالضبط،
في.
احسنت. Um, it's really good to understand that the remodeling phase is a phase that exists before a bone is fractured. And when we say the last stage of bone healing is remodeling, we mean that's the return of norm, which is remodeling that has existed even before the fracture was healing. Bone is on constant remodeling, and the final stage is the return of the remodeling of bone, which after healing exists. المعلومة الثانية اللي بدي أحكيها، ركز الشباب يركزوا على ال understanding of the difference between primary bone healing أو secondary bone healing، أو بتلاقوا ببعض المراجع العلمية direct bone healing أو indirect bone healing. شو الفرق بينهم؟ حكى الدكتور محمد كلمة كثير كويسة وإلها علاقة برضو بالريموديلينج، إنه بالبرايمري بون هيلينج دايركت بون هيلينج what do we mean؟ إحنا بنحاول نضحك على الكسر بحيث إنه الجسم ما يعرف. we reach absolute stability. We apply the understanding of bone healing in our practice in accordance to the character of the fracture, that this can be applied. فبنستعمل هذا الشيء لمصلحتنا وبنضحك على البون. we reach absolute stability، وبالتالي bone doesn't understand that it has been broken، وبالتالي it skips the stages of healing directly to remodeling as if there was already remodeling. صار كسر، اجيت انا تعاملت معه، I applied the rules اللي انا متعلمهم بهاي المحاضرة، و I applied absolute stability with contact، وبالتالي bone continues، the apparatus continues into remodeling، وهذا remodeling heals bone back into norm. How to apply this in the in day-to-day practice؟ هذا الشيء، هذا الجزء المهم، لانه كل الاشياء المعلومات هاي تقدر تقراها باي كتاب، بس اللي مهم تستفيدوا منه شباب how to apply it in real time in real life على المرضى. your understanding of bone healing, how is it, what is it, how to apply it to the benefit of your patients. والله يعطيكم الف عافيه جميعا.
عافيك سيدي، العافية.
دكتور محمد انا عندي سؤال بعد اذنك.
تفضل. تفضل.
حكيم احنا هسه البرايمري بون هيلينج اللي
اه
حكينا عنه باي جاب
Yes.
فيلينج، هي فور اكزامبل يعني احنا لما يكون في عندنا بليت ونعمل بليت ريموفال مكان السكروز بيكون في جابس على سبيل المثال، هي يعني it will heal by primary bone healing. يعني هل في سايز معين لازم تكون الهول حتى يصير في برايمري بول هيلينج يعني للجاب، مش انه باي هافيرجن سيستم يعني.
بس عيد آخر إشي لو سمحت فيصل، إيش آخر
يعني
إشي؟
احنا لما مثلا نعمل مش في البرايمري بون هيلينج، قلنا يا بصير عندنا هافيرجن كانالز تعمل برايمري بون هيلينج، يا في جاب
يس.
جاب برايمري بون هيلينج اللي هي فيلينج
أوكي.
للجاب. هسه احنا يعني زي لما نعمل مثلا بليت
اذا بتسمح
ريموفال.
لي دكتور محمد سعيد، اذا بتسمح لي اعطي مداخله. انا عارف انه انت
سيدي عادي، أوكي.
المحاضر هون، بس اذا سمحت، اذا اني فهمت السؤال منك فيصل اللي بيسال صح؟
نعم سيدي نعم.
اذا اني فهمت السؤال، هو السؤال فيه نقطتين. في النقطه انت سالت عن الجاب اللي هي فيها مكان السكروز بعد ما نقيم البليت، ولكن انت
صحيح.
فعليا عمالك بتسال عن شو هي الجاب اللي بتصير، او what is the gap that permits the
برايمري بون هيلينج.
formation of bone او healing by primary او direct bone healing by direct osteoineural repair
صحيح سيدي
by
يعني.
remodeling straight away if we apply absolute stability.
انا
الان
سؤالي
هذول
عن
سؤالين.
نقطتين.
انا فهمت عليك. هسه بدي احكي لك الموضوع على السؤالين. السؤال الاول، um, the gap between two fracture ends that can permit uh, uh, absolute stability, that can permit
برايمري
direct
بون
bone healing by sternal repair is 2 millimeter. More than 2 millimeter, you will not have you will have secondary bone healing, indirect bone healing by hematoma formation اللي هي كل stages of bone healing. They found in research that a gap up to 2 millimeter, not more than that, if you apply the stability, the proper rules of stability, absolute stability, then that's the number. Above this number, you will never have it. You will never primary bone healing. You won't have it. Below this number, you are expected to, up to this number, you are expected to have bone healing. بس احنا بنرجع بنقول if you have this type of character of fracture, then just compress it and then you will gain the benefit. But this is just for the sake of knowledge. Yes, it's up to 2 millimeter. الآن نحكي عن موضوع ثاني، موضوع الهولز. هذا موضوع فيه controversy كثير، اللي هي critical. What is the critical number for a gap in the bone, a hole in the bone? What is the critical size that can fill up with bone? أنا ما عندي fracture، عندي gap in a bone. هذا له هذا موضوع فيه controversy. ما حدا بالعالم متفق على رقم معين. What is the maximum size of a hole that if you leave in bone in which it will fill. ولكن بيعتمد على تفاصيل ثانية الموضوع. كيف يعني؟ يعني is this hole induced by corticotomy or is it a post pin or post screw which has been there for a while. هذا معلومة الأولى. معلومة ثانية, what's the age of the patient? What's the site of it? Is it metaphyseal? Is it diaphyseal? What's the age of the patient? ففي تفاصيل كثير بتحدد what is the critical size of a gap or a hole in the bone that can fill up. I hope إنه أنا I answered your question properly if I understood it properly.
شكرا حكيم.
حياك الله.
دكتور محمد السعيد، الله يعطيك العافية.
الله يعافيك سيدي.
well done، محاضرة جميلة، الله يعطيك العافية. احنا بنحب نشوف interaction أكثر من الشباب وأسئلة. اسألوا أي شيء بخطر ببالكم اسألوه. دكتور رازي طبعا شكرا لمداخلاتك. الدكتور ناصر دائما جهودك مشكورة. السؤال اللي سأله الدكتور فيصل على when we remove the plate or screws، يعني you can consider it as a fracture by definition the continuity of bone. طيب بيعتمد على أي type of healing when you want to fit, when it's going to fill the gap that's left by the screw when you remove it. عشان هيك في كتير controversy على هذا الحكي إنه أول شيء the indications of removal of plates لأنه you have an incidence of refracturing after you remove the plate and screws due to this fact. واثنين, you're going to support the limb when you remove a plate and its screws, and by what type, because you want to prevent for a period of time refracture, to have time for the secondary, let's say, type of healing to kick in. valid question فيصل, very nice question, بس في عليه controversy كثير. وطبعا الدكتور رازي جاوب عليه بطريقة حلوة كمان. دكتور محمد سعيد يعطيك ألف عافية وبارك الله بجهودكم جميعا. الشباب المقيمين التذكير كمان مرة على الحضور وضرورة الحضور، وهذا كله يعني إلكم عم بنعمل. يعني لما بنطلب من الأخصائي إنه يحضر محاضرة بأخذ من وقته وببذل جهد وبيحضرها، يعني هو الموضوع إلكم، و you will enjoy it more لما بتحضروا عن المحاضرة. believe me, you will enjoy it much more لما تحضروا عن الموضوع، اللي تكونوا جاهزين لما تسمعوا تناقشوا تسألوا أسئلة. this is how you build your knowledge. وأي سؤال عن الموضوع هذا you can bring some x-rays، طلعوا على nails, plates, absolute stability, relative. you can bring your x-rays وتسألوا. applied knowledge is very important. والله يعطيكم العافية جميعا.
الله يعافيك سيدي.
الله يعافيك سيدي، يعطيك العافية دكتور محمد.
الله يعافيك ناصر.
إذا ما ضل أسئلة ممكن ننهي اللقاء. ضل حدا عنده أي سؤال؟ أوكي، معناته يعطيكم العافية. قبل ما ننهي لقائنا احنا هيك بنهاية هاي المحاضرة وصلنا لنهاية أول موديول عندنا اللي هو موديول تروما أند بيسك. اللقاء القادم راح نبدأ ب تيومرز موديول. وزي ما عودناكم بنهاية كل موديول في عنا موك إكزام نعمله بالمادة السابقة. محاضرتنا الجاية راح تكون الثلاثاء. الأربعاء الجاي إن شاء الله راح يكون في عنا موك إكزام بالتروما أند بيسك، مينلي المواضيع اللي انعطت بها المحاضرات، بس ما بمنعش إنه يكون في عنا أسئلة تروما عن أي شيء ثاني أو أي شيء ثاني بيسك. فاستعدوا للموك إكزام القادم بشكل رئيسي من المحاضرات اللي أعطيناها. الله يعطيكم العافية.